Look now at Hashimoto's disease, another condition still under the endocrine disorders that affect the thyroid gland. So earlier we talked about Graves' disease being an autoimmune condition, and as well Hashimoto disease is another autoimmune problem that results in production of antibodies that go and attack the thyroid gland. So actually, this disease, as you can see, was actually described by Dr. Hikaru Hashimoto. So that is the person who led to the disease being called Hashimoto disease or Hashimoto thyroiditis. So the ultimate event is that we end up having some sort of inflammation, and which interfere with the thyroid gland producing thyroid hormone specifically. The other names that Hashimoto disease is called, so we can regard to it as Hashimoto's thyroiditis or chronic lymphocytic thyroiditis or just autoimmune thyroiditis. So we know from the normal physiology that hypothalamus secretes thyroid releasing hormone, which in turn goes and stimulates the pituitary gland to produce the thyroid stimulating hormone, TSH, which again in turn goes to the thyroid gland to stimulate it to produce the thyroid hormones, specifically T3, T4. Then these hormones go into blood, and then they will go to the target cells. So when the thyroid hormone levels basically are low in blood, we will have negative feedback mechanism being sent so that we end up producing more TSH and TRH, and then that in turn leads to an increase in the amount, and vice versa. So that is the normal negative mechanism that helps in the regulation of the production of these hormones. However, when we talk about Hashimoto, it being an autoimmune condition, there is production of antibodies, and there's some very specific antibodies. So there's some antibodies that are produced that end up affecting what we call the thyroid peroxidase, which is a very important hormone, a very important protein that helps in the production of the thyroid hormone. There's also another antibody that is produced that acts against another protein called thyroglobulin, which is an important protein also in the production of thyroid hormones. However, the main antibody that really affects, in this case of Hashimoto, is the antibody against the thyroid peroxidase. Okay, so when this antibody is produced, affects the thyroid peroxidase, in turn, that ends up affecting the production of the thyroid hormone. So the attack of the thyroid gland leads to some sort of inflammation, and if it's chronic, we end up having thyroiditis over a period of time and impairing the production of the thyroid hormones, so the T3, T4. As a result, we start having a gradual decline in the functioning and eventual underperforming of the thyroid gland, so leading to a state of hypothyroidism. So as you can see, this diagrammatic illustration of antibodies being produced, then they go to the thyroid. In the thyroid gland, they affect these proteins that are important for production of the thyroid hormone. Still, the presence of these antibodies cause some sort of inflammation. Now that's why we even call Hashimoto's thyroiditis disease. The ultimate event is that we end up having hypothyroidism occurring. So in terms of who is affected, so there is no much difference from it and Graves' disease. We still know that it can affect people at any age. However, this one is a bit prevalent in an older age group, as opposed to Graves'. Graves' is very prevalent between 20 and 40 years. This one is prevalent above 40 years, so 45 to 65 years of age, more common in women than men. That is the same feature we saw also in Graves' disease. But more importantly, also, it's more common in whites and Asians than in African Americans, or basically Africans. So the prevalence of Hashimoto's thyroiditis is around 800 cases per 100,000. So you can see it's not like it's a very rare condition. And actually, Hashimoto thyroiditis is the commonest cause of hypothyroidism. So in terms of risk factors, who can be affected by this condition? As we've already seen, things like gender, the women are mostly prone. Then people around the age of 45 and above. So age is also a risk factor. But also if there's a family history of Hashimoto, then the offsprings are predisposed, or people within the same family. But there are other environmental triggers such as stress or exposure to some radiation. But also presence of other autoimmune conditions such as vitiligo and so on can also trigger this autoimmune thyroiditis. So in the clinical features here, I want you just to think of what we would expect in hypothyroidism, because we said in Hashimoto thyroiditis, the ultimate event is we end up having hypothyroidism. So because of low T3, T4 levels, we expect that metabolism will also go down. Therefore, these patients will be fatigued, lethargic, because they're not producing enough energy for any activity. We expect some weight gain because the rate of anabolism is lower than the rate of catabolism. So basically, we end up having less breakdown of nutrients and glucose, but we are having more glucose being taken up, or glucose being taken up in the normal proportions, but less breakdown. So that's why we are saying the levels of anabolism is higher than the level of catabolism. So then cold intolerance, remember we're not producing we're not generating heat or warmth from metabolism, because the hypothyroidism leads to less metabolism. So things like joint pain, constipation, dry and thinning hair. Actually, we have some sort of hair loss when we have hypothyroidism, and this is because the lower levels of the hormones affect the base of the hair follicles, and then we have problem with production of the hair, and also they start falling off. Then we have an effect on the menstrual cycle. Then people have depression, memory problems, and also there's even slowed heart rate or bradycardia. More on the clinical features, sometimes you have this disease progressing, and then we end up having an enlarged thyroid leading to goiter. Remember, thyroiditis is a form of inflammation still, so we might end up having some sort of thyroid enlargement, which is goiter. And also another classical feature is the formation of myxedema, which is basically a skin kind of problem, edema-like skin condition. So this is also a feature that is seen in some cases of Hashimoto thyroiditis. However, not everyone with Hashimoto's disease might end up developing hypothyroidism. As you can see, this is not a disease that happens all of a sudden, as in it's a chronic kind of problem. Okay, so not everybody will end up with hypothyroidism. So these are the features we've just talked about in a nutshell. So it can affect your mental states, heart rate, muscles, the extremities, the skin, intestines, hair loss, and all that. Now, how do we diagnose this problem? So obviously, THS test is a very sensitive one. And in this case, we will expect a high level of TSH. Reason being, because of the destruction of the thyroid gland, or the proteins that are responsible for production of T3, T4, will have lower levels of T4 and T3. As a result, the negative feedback will keep being sent, and that will lead to more production of TSH. So TSH will be elevated. Okay, you know, the issue is not the pituitary, the issue is at the thyroid gland. So the T3, T4 will continue being low because of the problems we are having with the production or secretion. However, we will continue producing TSH from the pituitary. Then we have T4 levels. So obviously we expect this to be lower than normal. And some very important tests, especially for the antibody tests, we want to see whether we have elevated anti-thyroglobulin antibodies or anti-thyroperoxidase antibodies. Then we have imaging tests like CT scan or ultrasound. So these are just some test results of a patient. And you can see what we look at: TSH, T3, T4 levels. TPO is the anti-thyroperoxidase antibodies we're looking for, and thyroglobulin antibodies here. Okay. So finally, in management of Hashimoto's disease, so the mainstay management of this problem is basically a lifelong treatment with a synthetic version of thyroxine, so which we call levothyroxine. So this one is given to a patient, so the patient is supposed to take it pretty much for the rest of their life. But even on top of that, there are other things that we need to be taking care of. Some of the clinical picture manifestations we raised, like cold intolerance. So we have to protect against cold, but by monitoring the temperature of the patient and also around the patient. So promoting rest, remember the issue of fatigue, providing food that is high in fiber, remember the issue of constipation, then managing respiratory symptoms. You see, we actually talked about some of the respiratory manifestations that we might have in this condition. So I want to bring it to a close.